last session for this afternoon, or this component of the afternoon, sorry. I'm not going to even need a bit of paper to introduce Dr. Marg Fry, because I think she's presented quite a few times already, but she's also one of the scientific conveners for this conference. She's also somebody I've watched for years and years and years, and she's inspired me. But I'm mostly interested now because a lot of the work she's been doing over the last sort of 10 years is making sure that what happens to you when you get older and you present to an ED means that you're going to be a bit safer and better looked after, and you might get some pain relief and people might care about you. And since I'm on that side of 50, I'm thinking that anything she does from now on I'm going to benefit from. So I'm really looking forward to hearing anything she does.
Thanks so much. And, you know, time does just go. I can't believe it. It's like, you know, on the other side of 50 myself and facing potentially some of the problems that I've been talking about. Thank you so much again for coming along. It's always the last few hard yards at the end of a conference. This is actually, you know, as an emergency clinician, this was not on my radar. And it's the advantage of many of you make a difference, and you have interests and passion around certain elements of your work, maybe not all. But what this study reminds me is the importance of having those champions. So with that, I'd like to acknowledge really the lead author on this study is Marion Harris. And she was part of my mentor program in the health district that I work in. And her passion, she was part of the ASSET team, the aged care response team in the ED, in one of our district emergency departments. And she was absolutely passionate about improving the quality of care for people with Parkinson's. Now, I don't know about you, but as an emergency clinician, when she first came to me, I said, "Are we getting many through?" So it is that thing about just always we need those champions, and it's what, and knowledge does change us and make us think about what we do. So this is a study looking at her introduction. I helped her with the study, but I really want to give her credit for not just the inspiration and innovation of this idea, but really making a quality difference to people. And every day you do this, and this is just one exemplar of it that I was privileged to sort of work beside. So this study really enlightened me on the sort of concerns around Parkinson's in our country. And every day there's new diagnoses of people with Parkinson's disease. In fact, really almost 32 new diagnoses every day. By and large, still the cause is unknown, but in Australia, and it's climbing, we have over 80,000 people that are experiencing this condition. And in fact, one of the facts that was enlightening for me is it's actually, I have to say, affecting people much younger than me. So it is a concern in terms of the prevalence of this disease across our nation. And it does actually have a significant economic burden in terms of the cost of Parkinson's disease globally, over $8 billion per year. So it is a significant disease, and it's more prevalent than prostate cancer, then ovarian cancer, and then cervical or leukemia. So we often, it may not be on our radar, and my goal is to hopefully put it onto yours and wonder what's going in your ED, what processes are going on for this group of patients. So in background, there are millions of people, 9.3 million people experiencing this disease across the world. As I said, the causes really are unknown, and the treatment, by and large, is symptomatic, and that's where we as emergency clinicians can play a significant role in the quality of life for these patients, as we've heard earlier today in relation to other vulnerable groups as well. It is a chronic, progressive disease, and so we need to try and optimise the care. So what are the risks for our patients? Well, there's no doubt if you have Parkinson's disease that you're at greater risk of falls, for example. and often, as you'll see, will experience those people coming through the ED. But more importantly, because the actual treatment for Parkinson's relates to symptomatic relief, in fact, changes to medicines for this vulnerable population can actually cause catastrophic events for these people that actually not just affect their quality of life, but can certainly affect things like hospital admission, length of stay, mortality and morbidity. So it is something we need to be mindful of, this vulnerable population. So Marion came to me as part of the mentor program and said, I want to look at improving the quality of care for people coming through with Parkinson's. So what we did is she had the evidence of sort of it's becoming prevalent and more people are coming through her ED. I'd like to look at it, but more importantly, I want to test an intervention. So we did a pre-post study, and what Marion designed is in her ED, she would create an ED care bundle. She'd gone to the literature to see what worked for this particular vulnerable group of patients, and she designed this whole care bundle with the emergency team, which I'll go into in a minute. The emergency department Marion was part of was Hornsby Emergency Department, and they really have pioneered some of this work that I'm going to convince you that we should be doing in our EDs. And what from her data she found is there was a person coming through the ED with Parkinson's on average about once every 1.5 days. So it's, even though I know it's not large numbers, it is numbers coming through our ED. So what we did was we developed this bundle that we were going to test, and it was around a clinical pathway. It was around actually creating a medicines bundle, and I'll give you more details about this. It was creating changes in EMR. It was creating alert systems within the ED. And obviously, as we've heard a bit with the behaviour change wheel, one of the arms was to look to improve the education and knowledge of staff about this condition. So what did we do? As part of looking at measuring the impact of those interventions, which I'll call our bundle, we looked at a medication audit, we undertook patient interviews, and we undertook nursing surveys. They're the key data collection points that we had for our study, and we were comparing basically pre-implementation of all of those elements of the bundle with post-implementation, and we collected our data through those methods. So the first thing, though, which sounds easy, but in fact the first thing was she created this clinical pathway for Parkinson's patients, which was developed and convened through a multidisciplinary steering committee in the emergency department. But that wasn't good enough for her. She decided that actually she needed some better interface with EMR, and was the first in the state to develop a flag for Parkinson's patients. Not only that, she also developed within that, working with government and EMR and the hospital database people, a referral icon for pharmacy. And as you can imagine, pharmacy delays may well contribute to the quality of care. In developing the clinical pathway, what the team realised is that often delays in getting specific Parkinson's medications were an issue. And so what she created was basically a Parkinson's box, which had these medicines to try and reduce delays. So again, working in the ED, working out how to do that. In addition to that, she developed with the emergency team learning packages both for medical and nursing staff. And one of the areas that she felt was there was very little information in the ED. Many of us have waiting rooms, many of us have people waiting, but we don't often provide them with preventative health opportunities to learn about their health or their conditions. And so she actively went and sourced information, flyers for the waiting room and for staff to give out. And that was just the element of the care bundle. So in EMR, our electronic medical record, she developed for patients with a history of Parkinson's. Admittedly, it had to be entered first, but subsequent visits by that patient would always flag that they're a Parkinson's patient, so that medical staff would be alert to go and see these people. It not only activated the Parkinson's icon, a bit like this sort of sepsis bomb, but also it activated a referral for the pharmacy team. And once it was entered, it didn't have to be entered again. As part of the strategy in trying to improve the quality of care coming from pharmacy, what she did, as you can see, is she created a sticker for the medication chart to alert, because her concern was not only are people in ED not knowing that there's Parkinson's patients, but the interface with the ED and the ward was letting us down. So what she developed was a patient sticker, so that when patients went to the ward, staff would be alert that this is a Parkinson's patient. She relocated the medicines for Parkinson's specific patients to the ED, and she actually had obtained a Parkinson's pill chart, if you like, so patients bringing in medications could be readily identifiable to the staff. So I guess what we were looking at is, whenever you go to do a study, the point of collecting data is to be able to measure something. So from the data, we did a pre-audit. I'm not going to present that here, I'm just going to talk to that. And basically, as you could imagine, there were the anticipated adverse events that you would all be sitting there already aware of. There was poor documentation, failure for medication adherence, failure for appropriate review, failure to document that they were Parkinson's patients. So when we did the pre and then the post audit, I want to give you some of the results. So we had about 33 in the pre audit and 38 patients in the post audits, and you know the average age and the gender were pretty evenly split between the two groups, and the majority came by ambulance, but the majority of our patients always come by ambulance, so that's nothing really new. However, what we did notice straight away in the post audit that was statistically significant, but more importantly clinically relevant, was the prescribing of Parkinson's drugs did actually increase. So for those people with Parkinson's, their medication prescribing was seen more often in terms of the post-audit. And more importantly, there was a 50% reduction in Parkinson's medication errors. The numbers weren't huge, so we could say that, you know, how reliable it is. But nonetheless, even if it wasn't statistically true, it's a trend that with the introduction of the bundle has proved important. And we saw a reduction in Parkinson's patients' errors. We saw a difference with all of these interventions and the bundle, as I said, I'd call it, in terms of medication delays. Now, for quality of life for Parkinson's patients, this is critically important because it is about symptomatic relief. And so a reduction in ED of medication delay not only just is important statistically, but clinically has a profound effect on the quality of life for these patients. And the introduction of this bundle made that difference. Interestingly, we may not necessarily think about it, but there are actually lots of contraindications for drugs for Parkinson's patients. And there was a difference between pre and post in a reduction in the number of contraindicated medications being not only prescribed but then administered. So in terms of, again, quality of life, this has really made a significant improvement. And most importantly, in review of patients by pharmacy, there was an increase in the number of pharmacy reviews that was also statistically significant. But that's not surprising because there wasn't an alert before we had an alert. So it's not surprising that's improved. In terms of documentation, we found that there was just reasonably good documentation that they had a Parkinson's history, but it was 100% in the post group, which is fantastic. Medication stickers were there. They weren't there in the pre-audit, but they were there in 73% of the documented. And you can say there's still room for improvement, but at least we're on a trajectory that's positive. More people were admitted in the post group, and I wonder if that's because of more consideration of their comorbidities, such as their Parkinson's disease. But most significantly, and this is where we, by introducing interventions that can make a difference, is the mean length of stay in the ED was dramatically reduced by this more coordinated case mix for this particular population. So sometimes we just think, oh, we can't make a difference, and we heard stuff about post-resuscitation, but we can have a profound difference with often the most small changes for our patients. So then we went and we did a nursing survey just around trying to see knowledge capacity around Parkinson's. I won't read everything out, but we had a good response rate in terms of the survey, and many of the nurses had an appreciation for Parkinson's disease and specifically the symptoms that they might encounter. But this was post the education program as well. The majority of nurses, though, appreciated the importance of medicine. They appreciated the maintenance of symptom control. They appreciated, the vast majority appreciated the importance of not omitting Parkinson's drug. But as you can see, we've still got a little bit of work with one thinking it's fine. So in terms of access for the after-hours pharmacy and where Parkinson's medications were kept, the majority of the nurses knew where to find it. And again, in terms of the contraindicated medicines for Parkinson's disease, the vast majority of nurses were aware of that. So it's very positive in terms of having a local champion that's providing this knowledge transfer to the staff. Most of them reported it's important in terms of the having the pathway. Most knew of the pathway. Most had used the pathway because some of it was an evaluation of the pathway. Most found the pathway easy to follow. But I think when you're developing these sorts of interventions with the emergency team, then hopefully that will translate into utility and usability more broadly by staff. So the nurses found that generally the introduction made them more knowledgeable about Parkinson's disease and how better to care for this vulnerable population. What we did want to see, though, fantastic, thanks. What we did want to see is, in fact, and I cannot advocate enough the importance in our work, and I don't still do it enough. But I'm doing a study in Tasmania that's doing this, and this study also has done it, where we try to engage and involve the consumer in understanding the quality of the care that we're delivering. Because at the end of the day, it doesn't really matter if I make a difference for nursing staff if I'm not making a difference for patients. I've got to try and engage both to end in a quality outcome. So what we did is we rang patients who experienced our ED in terms of having a history of Parkinson's disease. And it is amazing. I think it's an amazing experience to be able to do this in terms of finding out what's the quality of our service by the end users. And I think this is important. So when we rang the people with Parkinson's who had been through the emergency department, they may have been admitted, and we rang them once they'd left hospital, so they weren't just discharged patients from the ED. What is interesting is probably, and I don't have to, I think, read everything out there, but what was a little bit disappointing was how few actually had a regular GP. And while they had a neurologist, but often they might only see the neurologist once or twice a year, that engagement in primary health care and that ongoing monitoring, the fact that, you know, so few had a consistent GP, we thought was disappointing in terms of continuity of care and sort of monitoring of their condition. But we interviewed, we had 37 interviews. Some were patients alone, and some were with carers alone, and some were with patients and carers. And the vast majority, not surprising, is the people with Parkinson's were male and their carers were predominantly female, which sort of goes in line with our society at this stage. And so what we found is the majority actually felt very anxious about coming to ED. The majority were allocated low triage categories, and that may not be unreasonable until I show you why they came to the ED. Then you may choose to consider whether that's appropriate. The vast majority came with falls, which is not surprising. And in fact, they felt, though, the vast majority felt that the ED staff did appreciate and understand about Parkinson's disease, the risks around mobility, the risks in terms of medication adherence and so forth. So when we spoke to the patients, what they identified is generally they reported that when they came to their ED, most importantly, their home schedules were respected. One of the critical things is not to squeeze them into your medication regimes. It's critically important for this particularly vulnerable group that you adhere to, unless there's sort of life-saving interventions why you can't, but to adhere to their home schedules. And most actually felt that that was respected. Most patients felt understood, and actually most patients felt that they were formed part of the decision-making processes around their condition. However, as you can see, as we're all time pressured in our EDs, the average mean length of stay for this group was actually nearly 5 hours, and that's tough for EDs trying to manage that time. 11 patients had been seen by Allied Health, and 41 had been reviewed by pharmacy. But sometimes they may not know. So remember, this is about the self-reporting from patients. The vast majority had a diagnosis of musculoskeletal injuries or pain, which is not uncommon since most of our patients present in pain. But it is interesting, a reasonable amount were admitted, only a small amount were discharged home. So there's serious patients that need to have ongoing care for their Parkinson's condition once they're in hospital. Many patients reported that they had presented more than once to the ED, so it's a vulnerable group. Many patients, when they're discharged, we need to make sure that they've got adequate follow-up intervention. And in fact, many in New South Wales, I'm not sure about other states, there is one down south, but actually we really don't have any Parkinson's specialist sort of community nurses within our health system, bar one. So I acknowledge and respect the one that we've got. So certainly down south they're very lucky. So I guess in conclusion, one of the reasons I love research and I encourage you to do research is I look at the world with a lens of a clinician. And it's not always true. And sometimes you need research to give you a new appreciation or a new way of looking at your world. So this study, though, must acknowledge an amazing impact on practice for a vulnerable population with the introduction of this care bundle. It is, I think, extremely innovative in terms of the quality of care for this particular vulnerable group. I think in all of our EDs there's opportunity to do better, so we need to continue to look at this, but there's no doubt that a cohesive team implementing interventions through good communication and building knowledge is an answer to ensuring more quality and consistent care. Thanks. Yeah, it's a great question. I think anything that the minute you want to do something in the electronic medical record, if any attended Matt Lutz's talk, it is challenging. But I know for the pharmacy, because in creating the clinical pathway, pharmacy were on that steering committee, so there was great engagement in terms of pharmacy. So one of the ways to break down barriers is just to bring them in with you. So for the referrals that they were strongly supported and felt it would make a big difference. For EMR, for the icon, a bit like the sepsis bomb, it actually wasn't too difficult for that, to create that alert, and then once it's in there, it would come up for each person. So I think at times you can pick to do things in EMR that are even more challenging. This on the scale was actually, I think, probably, you know, we don't want to use a scale, but it was quite easy. But it was not, you know, it didn't happen overnight. Yeah. Mm. Yeah, so the answer is we're not doing that in our, not because we don't want to, but you're ahead of our district in terms of doing that, so it's fantastic, and you'll sort of probably pioneer some of that stuff. The electronic medications is coming in, and in terms of the Parkinson's, we have created the alert across different EDs in our health district, and I know that the Ministry of Health and Parkinson's Australia want to see this rolled out further across other districts. So I'm just finishing as soon as I get to a sort of writing this one up for publication, but you know, I'm a bit busy. But I think as soon as it comes out, it'll give the ammunition that many need to go, actually, we need to do this in our area. And I think this is one vulnerable group, and I think those, you know, it was interesting with John, well, you get an alert and then you get sort of alert desensitisation. But I think when it comes to comorbidities, we actually do, at the complexity of our patients, once we introduce comorbidities, should change our decision gate. So I do think for things like this, those alerts do need to be there. It might not stop you from doing anything, but it needs to be considered that, do I need to change my management plan because I now realise I've got a patient with Parkinson's or whatever condition it might be. Mm.
Okay, last afternoon tea, and then the last plenary session. Thank you all for celebrating the work of the 4 people who've just presented.